That's perfect. I'm talking about fractures of the proximal phalanx, as you said, one of my topics I like very much, because at first I have to tell you a story. On the left, you see my teacher, Jörg Böhler, and he said 30 years ago to me, you see me here on the right, a little bit younger, I have discovered a new method in a paper in which these fractures can be treated dynamically, but without surgery. And I said, now we finally have proper screws and plates, and you want me to treat conservatively again now? And I continued screwing. So my colleague, Martin Leixnering, treated the next 50 cases conservatively, dynamically, operated with screws and plates. The result was clearly better with the conservative method. And so I promoted from Saulus to Paulus, if you understand what I mean. And I went out into the world and told everyone about the one and only true method to treat proximal phalanx fractures. Well, this sounds a little bit like a fairy tale, but you will see there is a lot of truth to it. You see here numbers from a period of investigation in the hospital where I was working from 2002, 2007. We had 16,261 hand fractures. You see here the distribution between the different fingers, and had 11,134 finger fractures. It was 68%, and the rest metacarpal and other fractures. And now you see here what we did. And on the proximal phalanx, you can see here, we treated only 12 operatively and 259 conservatively. And this number, it is years ago, did not change very much. Well, a little bit more to operatively, but still we are treating most of these fractures conservatively. And so the question is, why such a lot of these fractures conservatively? Because it seems to be easy to put some screws inside in that finger, but if you look at that table, complications are not rare. You see here, Trevisan et al., 41% restriction of motion, non-union, tendon ruptures, Stern et al., complications of plate fixation, 57% range of motion. Well, all of these patients had a lot of severe contracture of the PIP joints. So mostly 15 degree, 20, up to 30 degree, and that's not a good result. So how can you prevent joint stiffness? Make a decision if you want to treat your fracture open, percutaneous, or conservative dynamic. And if you operate, you have to get stable. That's clear. Because if you do an open procedure and you don't get stable, you need some kind of splinting afterwards, then you have definitely lost. So look at that. It's not made in our house, it's somewhere outside. And he put in 2 cross K wires and he had plate. And then he put a cast over it, and you see here the result. It's really stiff fingers at all. That's another case. What kind of treatment would you prefer? You would say there's a fracture, but here there is a fracture line, and maybe the patient had a private insurance or something else. I don't know why he put in that plate. Yeah, he put in that plate in a non-displaced fracture, and you see the outcome. It's a really mal-rotated finger which cannot flex, and when the father is a lawyer, then you have really bad cards in such a case. So the statement from Swanson is hand fractures can be complicated by deformity from no treatment, stiffness from over-treatment, and both deformity and stiffness from poor treatment. Also in the book from Green is written, phalangeal fractures that are stable and non-displaced can be effectively managed by body taping or splint immobilization. Improper treatment of unstable fractures often leads to stiffness and deformities. They both are right. Before some anatomical remarks, you see here that the extensor tendon is complicated system of fibers. It is not only one tendon, it's an interosseous hood. It's intrinsics, extrinsics. You see here on that drawing from my friend Langer, skin, subcutaneous tissue, extensor hood, then gliding structures, periosteum, and so on. And you have to respect all these anatomical structures, otherwise you get stiff fingers. What do you need for this fracture as prerequisites? Radiographic imaging, maybe cross-sectional imaging, I will talk about later on, particularly computer tomography, if you don't see enough on the plain X-rays. And yes, it's very useful in intra-articular fractures, but normally in shaft fracture, proximal phalanx fracture, you don't need a CT scan. Phalangeal fractures, 2 planes are enough, but they have to be exactly adjusted. As you know, in metacarpal fracture, you need 3 planes to also exactly one AP, one side view, and one 45 degrees rotated. What's very important is a clinical examination, not only before, also after your treatment, especially also after operative treatment. You have to look at your nail plane, and you have to look that your finger has the right rotation. They are converging to the tuberosity of the scaphoid. And if one is popping out of that line, then you have to take care. So what did we do? When I was a young surgeon, we used also this method. It was a static splint with a wire here. And yes, we got not so bad result, but it needed a long time after that fixation to get the finger in mobility again. What we do now is this intrinsic plus cast, and I will show you how we do the whole treatment. So look at this spiral fracture. How can this happen without traction? It's in 4 weeks heals this bone, but it not only heals, it gets also the right length, and also the widening of the bones gets diminished. And so the question appears, how can you stick out your tongue without someone pulls on it? Because the tongue is compressed by the muscles in the horizontal diameter, and so what can she do? She can go out of the mouth. And the same is here on the dorsal apparatus, because it is like a tension band. And if you flex your finger, the interosseous hood compresses, so to say, the proximal phalanx, also when it's widened or in a spiral shaped shortened, then the bone can only again go in its original position, because it has pressure from the lateral band, from the interosseous hood, and it's reduced, so to say, on the fly during motion. So in local anesthesia, I show you here a video. You see here a fracture short over the base of the proximal phalanx, a little bit dislocated to the dorsal side. That's a normal position of such a fracture, and maybe malrotated. So I start the video, and you can see here the injection into the hematoma of the fracture with aspiration. Then the patient is pain-free. And then at first you have to pull the finger in longitudinal traction to reduce the fracture and to bend the finger and to rotate against the malrotation. And you can see here quite good reposition. Also the plane of the nails is okay. Maybe he has still a little bit dislocation to the dorsal side, but that will be better if he is in flexion in the MP joint of 90 degrees. Then after reduction, we put a body tape on the fractured finger and the neighbor finger. Here with an applicator, there are also other body straps which are possible. And this body strap should hold the rotational deformity, should not hold the rotational deformity, it should hold against the rotational deformity if it's in conjunction with the non-displaced finger. Then the next step is that you make a dorsal to volar cast. It's important that you have a support on the volar side, distal to the distal palmar line, and not longer, because otherwise he cannot flex. And on the dorsal side, that's the conservative way to make intrinsic plus cast. You have seen before thermoplastic splinting. You will see later on also this model. But for years we used only the normal cast, and then hold your MP joint in 90 degrees of flexion, and the PIPs are free, and let the people move in flexion. 4 weeks, after 4 weeks, you remove your cast, and normally you get a really good result, also a good motion, maybe some lack of extension, but that will come in the next 2 weeks again. So here you see the modern way, how we do it now. And you will see later on also that we now make only short casts, not more so long like in this movie. And here you see some other forms of body tapes. And you have always to take care that in your cast, the fingers are in the right rotation and not mal-rotated. So what is the indication for such an intrinsic cast? Very good indication are flexion fractures, also oblique fractures or torsion fractures or horizontal fractures, or also severe comminuted fracture. You wouldn't believe it, but we have treated really severe comminuted fracture with this method, not intra-articular fractures, that's clear. And one is clear, the more distally the fracture is, the more difficult it is to regain reduction and stabilization, because these fractures tend to dorsal angulation if they are fractured very wide distally. So that's the ideal type for intrinsic plus cast. Also horizontal fractures can be treated with intrinsic plus cast. When the spiral fractures goes intra-articular, then no chance, then you have to operate, because he has problems. And the contraindication, it's clear, are intra-articular fractures. They have to be restored really anatomically and fixed for immediately exercising. So a case, see here, rotation trauma, middle finger right. It's a spiral fracture, and you would say, okay, it shortens. Should we treat it maybe with a plate or with screws? And you can see here the intrinsic plus cast. with body tape, and it healed in that fashion. It's lengthened again. It is also the widening diminished. And after 3 months, look at the patient. He has a really good free motion of that fractured finger. Here again, that was a surf lady which came in our hospital, and he broke his little finger in the boom during surfing. And we reduced her during a hand course in Vienna, and could show this short cast. That's what we do now. It was invented, or not invented. He made the Swiss guy, I don't know his name, he make it better because it's not so long as we do it. And it's really enough for the fixation of the intrinsic. You have to take care that you have really good palmar support. And here's the outcome. That photo I took in Egypt, in Sommer Bay, some months later, I met her again. And it was a perfect result of that finger. So what about the healing time? Many authors have commented on the lack of correlation between radiograph and clinical signs of union of the fracture. Smith and Ryder studied phalangeal tooth and hands fracture healing and found that the average time for complete bone healing was approximately 5 months. But the clinical healing time could return the work was about 1/4 of this. So normally, a proximal phalanx fracture is tight at 4 to 5 weeks, even when the fracture looks in the X-ray also as not healed, because you get always from the radiologist the result the fracture is not healed, and the patient come and says, "Oh my God, my fracture does not heal." But anyway, after 5 weeks, with some exceptions, yes, the fracture has healed. So the limitation of dynamic splinting, if that method does not work, you have after 1 week to make an X-ray, if you could hold your reduction, and if after 1 week you have a malrotation or an axial deviation, then you should go to an operative treatment. And look here we have it. She has some rotational deformity after, I think, 1 or 2 weeks. And then you can operate, but not like it is shown here with K-wires or with historic plates. You see here really bulky plates. And some words to the pinning method, because in our hands we did it also. It is not that what we want. Some words. Pan and co-workers reported on 109 unstable digital fractures treated with Kirschner pin fixation. Nearly 70% had fair or poor result. So if we cannot gain a reduction with a conservative treatment, we always use screws or blades, no K-wires. We can discuss it later on. Well, now to the open reduction and internal fixation. As I've said, we can use K-wires. We don't use it. Screws, blades, or external fixator. Yeah, in some limited, in some cases, maybe where you have a shotgun or something else, or a bite from a dog, you can use external fixator, but normally we use screws and blades. Don't use crosshead screws, because as we will talk later on, you have sometimes to put out the blades, and that screws you don't get out after 1 year. They are inside forever. So we have now tiny little plates and screws with hexa drives. Yeah, here, don't use external fixator, especially for such a fracture. I have this picture from a web seminar from the last week. I would never do such an external fixator. We have now multi-directional and angular stable screws, even when you not need it in every fracture of the proximal phalanx. You can use the non-locking screws also, but they have to be low profile and they have to be in an anatomical design. As I said, the screw features should be in a way with a hexa drive that you can remove them also after 1 year or later on. Here are some plates, grid plates, double row plates, correction plates. If you want to do a correction of a mal-rotated proximal phalanx, then it's very useful here to have this gliding hole. And also that plate here, that double row T plate, is very useful for intra-articular fractures that you can place your screws in the right way. They're a little bit curved and adapted at the curvature of the convex curvature of the dorsal aspect of the proximal phalanx. So you see here a case from 2000. The blades are too bulky, the screws are too big, and you see here the range of motion which he did gain, 0, 30, 90. That's not good. So what about the approach? Yeah, it's very common in the books that you do this lazy S. We don't do it because the incision, in my opinion, has an interference with the dorsal veins. With that bow, you cut here the vein, with that bow maybe here. So we do, since 20 years, a straight line incision and have much lesser swelling of the finger, and swelling always means consecutive pain. And we have not seen bad scars, which one could expect. So, generals, we go in straight line incision. Don't preparate the extensor tendon away from the skin. Go through the extensor tendon to the bone, maybe elevate the periosteum, but don't make here flaps and rooms for hematomes. Go in with a straight line incision. So how to reduce the spiral and oblique fractures anatomically? Yeah, sometimes it's a little bit tricky, especially if you have more than one, if you have more than 2 fragments with an intermediary or 3 or 2 fragments. We go in, we can discuss if we go in from the dorsal side. Some want to go in mid-lateral, but the best overview for the fracture you have from the dorsal side, and sometimes from the mid-lateral incision, you cannot really see the fracture lines exactly. Then you pull traction on the finger, then you have to take care that you have to expose the sharp proximal and distal fracture spikes. They must fit together and must really good fit to the corresponding fracture line. And it's not so easy to put screws on it, but because sometimes if you have not a clamp on it and you drill in, you screw in the screw, then it makes and you have only a double corticalis displacement, and that means 20 degrees of mal rotation. You have always to look during your operation how is the finger rotated. If you have your clamp on it, bend the finger, look from the volar side if it's in the right rotation. My teacher sutured his finger to the tuberositas of the scaphoid because he said to operate on extended finger is very dangerous. So he operated the proximal phalanx fractures always on flexed fingers. Yeah, it's not so easy to treat spiral fractures, that I already have said, because smallest displacement of double corticalis cause serious rotational errors, and it's not always so easy to find the fracture lines from both sides and fixed adequately with 3 screws. So here it would be the perfect fixation with screws, but anyway, we use mostly screws and plates if you want to give the fracture free for exercising. Here you see such a spiral fracture which was operated with a Crete plate, and here you can see also another fracture which was operated with a Crete plate, and here you see these small screws which at first give you the right rotation, and then you put over the screws this plate. And this you see here also something important, because you see here very short screws. Why is that so? Because that are angle stable screws, and they have not to be drilled through the other corticalis, because especially here in the volar recess, it's always a mistake to drill in the volar recess, and here are the screws popping out, and then they can't flex the BIP joint. So you can put in really short screws and not drilling the other corticalis. You see here the healing stable fixation after 8 weeks, and here our straight line incision, and here our result. But sometimes it goes not so good, and I ask you, would you be satisfied with that result? It looks pretty good, but look, this surgeon did not look during his operation on the volar side. He did not look if he had the right rotation, and that's what can happen. Yeah, again, in extended finger, you don't see the malrotation, but here it's clearly visible. And so we did a corrective osteotomy, a horizontal corrective osteotomy. And here you see again, the screws are all shorter than you would expect. And here the straight line incision and the extensor hood is divided in 2 parts, and then we close it with a non-resorbable suture, then that the patient can immediately exercise. And here you can see the good results after 10 weeks. Okay, you can see here the opposite. Well, maybe the operator thought a lot of screws would be nice for that patient, and you see here what is the outcome, flexion contractor from 60 degrees. And so you need in a lot of cases, or I got a lot of cases where we had to do a tenolysis, and also there, when you do it in a correct way, the results are not perfect. If you get a lack of extension from 50 degrees, 15 degrees, from before 60 degrees, you can be happy. So the commonest cause of post-traumatic stiffness, Tomin writes, is open reduction and internal fixation from proximal phalanx fractures. And anyway, whenever possible, use conservative treatment with dynamic intrinsic plus fixation, as I told you. And put in plates only when it is really necessary. So as a conclusion, as a first conclusion, 80% of all proximal phalanx fractures can be treated conservatively. Be aware that open reduction, internal fixation leads not to better results, and conservative treatment if there is no urgent indication to open up the fracture. If you decide to do an open reduction and internal fixation, you have to analyze the fracture if you can reach a stable fixation. The worst case is open up and not get stable and need immobilization. In open reduction, immediate post-operative physiotherapy is necessary, and that's really important. It's 50% from the result. Don't operate persons if you have not on the next day a physiotherapy 3 times a week, and there are surgeons who say to their patients they have to get up in the night at 12 o'clock and move their fingers, otherwise they get rigid fingers. So happiness is often within reach. You just have to see it. Keep your hands off plates and screws for proximal phalanx fractures whenever you can treat conservatively, and you will be happy. So if you are not happy, sometimes you have to do tenolysis. You have to pull out the plate when the fracture is healed. And also tenolysis is a procedure which you have to do in a way, not somehow, but you have at first go in through the skin, then you have to look, that are the periarticular structures, the transverse retinacular ligament, the oblique retinacular ligament, the central slip and interosseous hood. That's the most interesting thing for this tenolysis. Then the lateral slip of the extensor, the annular and cruciate ligaments. Sometimes the screws irritates the flexor tendon, and they get also articular contractures, and the superficial and deep flexor tendon. They are also sometimes involved in the stiffening of this joint. And then if you have all the extra articular structures released, then you can think on the interarticular fractures, but you have to go stepwise to your result. If your extraarticular procedures, if you can extend your joint, then you have not to go further on, but you should not begin to operate on your collateral ligaments on the volar plate, because that's the last thing. Then, but if you have all done extraarticularly, then you have to think on the volar fibrocartilage, on the accessory, on the main collateral ligament. And I show you here the articular strips. At first, you have to divide the palmar, the volar plate, from the bone and from the superficial tendon, flexor tendon. And then here, that's the second step. So you have to go between the bone and the superficial tendon and release the volar plate. And then you cut the volar plate proximally. Yes, now the release is done. And then you cut the check reins. You transect the check reins proximally from both sides maybe. And then you go on the accessory collateral ligament behind the main collateral ligament and cut out that triangle, which can also be contracted. So now you have this flap. And the third step is then, when the finger still is not to extend, that you look for the main collateral ligament. You see here the artery in the volar recess. And we will see you still have a contracture from 15 to 20 degrees. The DIB is 3. And now we have a look at the collateral ligament in extension. Well, on that side, it is not really tight, but you will see on the other side, it's really scarred. And in extension here, you see here the second scarred collateral ligament. It's a special knife, I dissected. And now you can see here how it gaps. And only if you dissect also the main collateral ligament, you get not the snapping in extension, you get a soft extension. Okay, on the end I have a case for you, a 4-finger case. The question is, what would you do? The patient came over WhatsApp to me from a doctor from my hospital, and he asked me what I would do. And I was not able to operate him because I was on a hand course in Vienna. And the skin was somehow damaged, but not open fractures. And so I said, reduce this fracture conservatively. And he sent me that picture. And you would say, okay, that's not what we want. He stands really beneath it. And yeah, well, that is somehow okay. Also, that one is not okay. And over the 5th finger, we can discuss. So now he tried it again, and he fixed this, the 2nd finger with a good reduction, and also the 3rd one was good reduced. And these two, well, we was not really happy. And so the question is, can we now operate only 2 fingers, or have we to operate all 4 fingers? Because I said you, if you operate, then you have to do immediate motion. But anyway, if we operate the 2 fingers and put it again in an intrinsic cast, we can exercise these 2 fingers. So we decided to put a plate on the 4th finger and to screw the horizontal fracture with the transarticular double-headed screw. It's a method which is an upcoming method. We can also discuss it. What is here the cartilage damage? What does that mean for the future? And you can see here the conservatively treated 2nd and 3rd finger, and the plated 4th and the screwed 5th finger. And we put it in the cast for 2 weeks more, and he got his dynamic splinting. And after 6 weeks, we put him out of the cast, and you see what happened here. He got a hypertrophic pseudotrauma non-union. But anyway, we know all that will heal, and after 8 weeks, that was healed again. And now the question, which of these fingers was the best from which one hurts less? And mostly the people say, okay, that one looks very nice, that hurts not. But interesting is that the screwed finger was hurting at the minimum, and the finger with the non-union was hurting at the maximum here. But anyway, you can see here he had a good physiotherapist and a really good outcome of all the 5th finger. Okay, this is the end of my presentation.